Good morning, everyone. Thank you for joining us today as part of Value in Health Week. I'm Dee Lowry. I'm Head of Value-Based Healthcare at Cwmtaf Morgannwg University Health Board. And you are with the session Value in Voices, Making an Impact. So I'm really excited to be joined by three amazing areas of work this morning and three fabulous presenters. But I just wanted to give you a little bit of context about what you're watching and what you're likely to see. So Value in Health Week has been organised by our fantastic National Value in Health team, who support us nationally with all of our value-based healthcare work. And this is an opportunity for all of the fabulous value-based healthcare linked projects across Wales to share and demonstrate the work that they've been undertaking, to inspire us, to share with us their challenges and the lessons learned, so that we can look within our own organisations and our own projects to see what can we learn, what can we do a bit differently, and how can we really make change for our patients. So I'm really pleased to be able to introduce to you this morning our three speakers. So firstly, we have Chris Lambert from Swansea Bay University Health Board, and Chris is the lead for MSK-OA Lifestyle Services. Then we'll be having Stephanie Ditcham, and she is the Programme Operational Lead for the Blood Health National Oversight Group at Welsh Blood Service. And then we have our lovely Amanda Willicott from the National Welsh Value in Health Centre, who's going to be talking to us about some of the work she's been doing as Programme Manager for Trauma and Orthopaedics. So there's a range of recordings that are already available from sessions that have taken place this week, and there's still more to come. They will be available to watch back, so do tell your colleagues if they haven't been able to join us live. And we'd really like to be able to gather your questions as the presentations are going. So feel free to add them in the Q&A bar. We'll pick them up and then we'll ask them once all of the presentations have taken place. So I'm going to hand over now to Chris. So Chris, if you want to take the driver's seat and look forward to your presentation.
Oh, thanks very much, Dee. Morning, everyone. As Dee said, my name's Chris Lambert, and thanks for having me on this morning. This chat is essentially about using PROMs to help patients prepare for surgery, especially within the area of orthopaedics. So taking you right back to the start of this project, which was about 2 years ago in the middle of the pandemic, and it started off really at its core as a research question around what are the effects of extended waiting lists on patients' health. And it's evolved over time from a research question into something that's really keyed into the current government's three Ps policy. So really, this is a little bit of a snapshot, I guess, of where the project has started and where it's ended up and where we are at the moment, and how we've used PROM data at the core of the project to help patients that are on the waiting lists. Right. So, sorry if my slide's skipping a little bit. So, as I said, it started off with a bit of research back 2 years ago, which I was involved in, and it's an ongoing piece of research, which is a core theme that runs in the background of this project. Around measuring patients' health that are sat on extended waiting lists in orthopaedics. And it looks at how we use that data then to help prepare patients better for surgery. So what we did back 2 years ago is we found a platform provider that we were able to digitally engage patients in using we invited to basically send a letter out to lots of patients on our waiting list and ask them to join our digital platform. And from there, we took lots of health data from them. So using basic PROMs, and we collected lots of health data. But what we realized were lots of other services in the health board were looking into this at the time, looking into engaging with patients, and for different reasons. So different departments in the health board were looking at contacting and communicating with patients from a validation perspective, waiting list perspective. So we started to work more collaboratively using our platform to try and plug in these other areas of the health board to engage and communicate with patients. So we weren't sending out multiple communications with patients. We were trying to get them to come through the one platform for orthopedic patients. So in this platform altogether, as I said, it started off very much as a piece of research, but it's evolved. And currently, we are collecting lots of health data. We're doing some anaesthetic risk screening, but we're also working on communicating regularly with the patients, so to validate the waiting list. So our validation team and waiting list team in Swansea T&O wanted to know, do the patients still want the operations? Some of them are asking to be removed, so we're able to validate our waiting list as well using this platform. And more of a key area of interest for me, because at the time I took on a clinical lead role as a prehab MSK prehab lead, and I was looking at how can we set up services for these patients that your support services, exercise, diet, etc. So I really wanted to know more about the health status, baseline health status of the patients. So all of these parts of informations then sort of come into the evolving platform, the digital platform that we were building, and it's still an ongoing project. It's still evolving. But that's sort of where we are at the moment with it. So just to give you a little bit of background on, this is data now that's probably 18 months old. This is our baseline data. This was a pilot we run to test the platform out. As I said, 18 months ago, we sent it out to some 300 patients that were sat on the waiting list, waiting for knee and hip replacement surgery in Swansea. And we really wanted to know what their baseline health status was. And for me, I was involved in the research behind it, but I was also involved as a lead for the prehab service. Prehab was new to Swansea Bay. We didn't have anything similar in the health board, so we really didn't know where to start in terms of what resources we needed to put into that service. So we used this health data on live patients on our waiting lists to build and plan the services. So as you can see, this is just one example of some of the data. This is our EQ5D data, but it was able to give us fairly accurate information on the spectrum of disability the patients were presenting with on our waiting list, so all the way from their mobility, their pain status, their mental health status. And this was one of the PROM measures we used to help plan services. So that previous data that I just shared with you then was able to be put into a fairly accurate business case where we were able to plan for the needs of the patients. So almost customize a waiting list support service for patients based purely on their health needs that we understood from the PROM data we were getting back from that pilot. So we were able to scale up the numbers on the pilot, understanding there was some 2,300 roughly patients on the waiting list at the time. We were able to scale up the numbers to get a fairly accurate reflection of the needs for these patients. So in terms of planning and building business case and resources, as I said, we used that information to put into it, and we knew that we needed some 900 exercise places, and that would vary from all the way from our lowest mobility patients needing hydrotherapy all the way up to some patients that were, a fairly high level of mobility, so would need to be pushed in the gym. So we had a tiered resources available for exercise. Then we understood that we needed some community physio appointments, because lots of patients were saying that they're actually struggling to walk around their house, and there was a falls risk. So we put in some community availability. We put in walking aids, and then one of the key features that our data come back with was that we had 12 to 13% of patients on the waiting list with a BMI status of 38 or above. So these patients are really in the sort of high risk, sort of morbidly obese category where surgery may not be appropriate for them with that current BMI status, particularly in Swansea Bay with the guidelines and policy around trying to get patients lighter for surgery and fitter to reduce anaesthetic risk. So we knew we needed to put provisions in to support these patients to help with weight loss. And we knew exactly around about the number of these patients that were on our waiting list from the data we were getting back in. We put in some pain injections to help support those patients with the highest pain demands, because we know from other services that we run in the health board in this area that they can sometimes help as an adjunct to get patients exercising and moving and get them more active again if you can improve pain management. And we also knew that some patients are really struggling at home with mental health issues, loneliness, isolation due to their symptoms. So we put in support via Red Cross as well at the time. So basically what we've done is evolve the research project and use that data, that health data from patients on the waiting list to plan services, to monitor patients, But it's grown from that. It's evolved into a more of a 3Ps project now, where at the moment we're using all of this data for various other reasons with anaesthetic screening. We're looking at signposting patients with BMI issues, smoking issues into the right support services via the platform. We can monitor condition change, which can help with referral priority. So we can flag patients that have suddenly had a huge deterioration in their symptoms between the 6 monthly intervals that we monitor them. And we can also pick up patients with comorbidity issues such as thyroid anemia, diabetes, that may require some bloods with their GP before they come into pre-assessment clinics. So we can also flag those issues up to patients to make sure that they're optimized before they come into secondary care clinics and surgery. That is it for me, actually. I think that's the last slide, but for some reason I won't switch on, sorry. There is one more, sorry. So this is just an example of our anaesthetic screening. So this is something our anaesthetic lead in Swansea has been working closely with our IT team on, and our tech colleagues, partners, to work out a low and high risk patient. So this is self-reported anaesthetic screening. So this is built now into the platform. It's not quite finished as a product yet. We're working on getting these reports back to the right people in the right departments, but essentially it's going to help with our anaesthetic team to understand the low and high risk patient need, which obviously is very informative information when it comes to planning for how many patients will need to go into our high and low risk centres for surgery. But that's an ongoing piece of work at the moment. And I think we're doing a question section at the end, Ian, so I'll leave that for the end. And if anyone's got any questions, then they can ask at the end. But that's it for me. Thank you very much.
Thank you, Chris. What an amazing and very timely presentation, as all of the health boards are now having to look at 3P. So yes, any questions, pop them in the Q&A. So thank you very much, Chris. I've got some questions, definitely, and I'm sure some of the other panel members may have as well. So next we're going over to Stephanie. So Stephanie, if you're ready with your slides, please.
Just making sure you can see it. See that okay? Yeah, cool. Okay, yeah, so I'm Stephanie Ditchum, operational lead for the anemia programme. This is preoperative anemia management. It takes a team to implement a national pathway. Got to give some background about the project first of all, because it was started a few years prior to the link with values-based healthcare. Although I'm operational lead for the programme, my main role is a blood health advisor within the blood health team in the Welsh Blood Service. The blood health team facilitates and supports the work of the Blood Health National Oversight Group to ensure the delivery of the Blood Health Plan. So the Blood Health Plan was first issued in 2018, and it's an NHS Wales document that lays out the strategy for blood health in Wales. From this, key work streams were identified, including anemia management, to work towards endorsing prudent healthcare, appropriate use and blood component use, and subsequently support the blood supply chain. So after some consideration about the strategy for anemia group, our workstream lead, Dr. Caroline Evans, who's a consultant anaesthetist in Cardiff and Vale, proposed a targeted approach with focus on the pre-op assessment setting, because this is a forerunner in clinical application of patient blood management. And we could use this then as a concept for proof of concept for wider anemia management. So due to the impact of variation in practice and the different pathways across Wales, our first objective was to get a nationally agreed preoperative anemia pathway. So we began that work in 2020. Working in collaboration with the pre-op anemia leads across Wales, the All Wales pathway was issued in December 2021. So although the pathway was agreed and everyone agreed with the standards, through the work, there was plenty of feedback from the services that said that they would struggle to fully implement the pathway due to local barriers and issues. So to ensure the pathway success, the ViH explored opportunities for funding for a dedicated resource that we could use to address these issues and support the implementation. So we successfully bid for value-based healthcare funding through the support of Velindra in 2022. Okay, so in our bid, we use literature to evidence the prevalence of anemia within the preoperative setting, and also the associated risks, so including increased likelihood of an avoidable blood transfusion. So the main cause of anemia is iron deficiency, which is modifiable and can be easily treated. The benefits of our programme were defined as prudent use of donated red blood cells, reduced demand for blood, improved clinical outcomes post-surgery, such as length of stay, reduced readmission, and improved mortality rates. We also wanted to ensure equity of care in the pre-op anemia management. And we, like I said, we wanted to gather the evidence of the benefit of anemia management for other patient groups. So the funding that we requested would cover a day a week for both a clinical and operational lead, 3 regional clinical coordinators, which are full-time, a day a week for BI and project management support, admin assessment 0.5 full-time equivalent. We also asked for some funding for Health Bud as well, so they could have localised money for service improvement, and that was 0.2 band 6. So to ensure the success of our programme, we had to maximise engagement and buy-in as quickly as possible. So basically, as soon as the coordinators started, they were tasked with establishing baseline activity against the pathway so that we could understand what the gaps and identify any barriers. So this is performed directly either through site visits or through Teams meetings using a survey, and we needed to get ourselves out there and form relationships. Very early on, it became clear how variable services were across Wales and therefore variability in patient care. We engaged with DHEW for some baseline denominator data to add context to the preoperative anemia management in Wales. So we didn't have a data standard to start with, so we used one to get the data quickly that was already established in England. We focused on patients undergoing procedures with high risk of blood loss. So this is greater than 500 mils or transfusion risk of greater than 10%. So this is aligned with our pathway anyway, and this would be the group that added the most value initially through the application of improved anemia management, as they would be the patients who would be most likely to need blood if they were anemic. In June 2023, we held a stakeholder event and shared all the information that we had gathered. It was the first time that many services had been able to visualise their own activity, and they could also see the variation then across Wales. As part of the session, we discussed national standards, which were agreed, and we also discussed next steps. Since then, we've been optimising pre-op anemia management and trying to align with the national pathway. The Health Bud funding that we secured has been released. Business cases were submitted from the Health Board, evidencing the value that they'd added through using this money. And this is the only aspect of the funding as well, which is reoccurring. The rest of the funding ends at the end of 2024, but we wanted to make sure that there was a monitoring and feedback process so that we could maintain control of it. So DHEW have been really, really supportive as well, and they've helped. We're currently developing a dashboard using the data standard that we described earlier. Currently, it evidences Health Board high risk surgical activity and also the number of patients screened for anemia and iron assessment, and we can link them then with the clinical outcomes that we discussed earlier. So prior to this work as well, last year we were looking at another collaborative piece with DHEW and the pathology leads across Wales to develop a pre-op anemia screen. So this test set is built within the National Laboratory Information Management System, and it's based upon reflex testing, which is aligned with our national pathway. So it aims to fast track anemia screening and the investigation for most common causes. So it's hoped that it will support patient management by mitigating the need for individual result review and decisions regarding subsequent add-on testing. So this hopefully should reduce repeat appointments for follow-up blood tests and should allow opportunity for earlier intervention. So we've been promoting this during our programme this year, and the test set's now live in the pre-op setting in 4 out of 6 health boards. Other work that we've been doing to address barriers to implementation of the pathway is education of various healthcare staff. So we've been delivering basic patient blood management training to all foundation doctors in Wales to support early anemia identification and management of inpatients. Some of these would ultimately need surgery. And this is going to be an ongoing programme as well, so this is going to be embedded into the foundation training for doctors. One of the concerns raised by nursing staff was about IV iron use in some of the pre-op services. So the historical IV iron products are known for a higher risk of anaphylaxis, but the newer products are much safer but maintain their stigma. So we needed to have some education to address that. And we've got some training sessions planned. The first one is next week. Our team also proposed developing a bank of resources to support anemia patient management. By housing and managing these centrally, it would release staff from administration of document management, prevent duplication of effort, and also ensure a consistent approach. So the toolkit contents have been agreed using user engagement, and the first set are available on the ViH website, and they include things like referral documentation and standardised patient information leaflets, all of which will be available in Welsh. Just wanted to give a little bit of insight into the data that we've got available for us now as well from the dashboard that is in development. So we obviously need data to evidence the success of our programme, but the services we support need it to monitor their own activity for ongoing service improvement. So this figure here captures the volume of the high bleeding risk procedures that we are most interested in at the moment. So you can see the impact of COVID in 2020. So our data shows that 88% of these patients are screened for anemia. So this is evidenced by a full blood count in the 12-week period prior to surgery. If it's performed prior to that date, it won't be captured in our data set. Of those that are screened, 37% of patients are anemic at the point of surgery. And then we can now link that information to clinical outcomes as well for patients in Wales. So here we are demonstrating the clear impact of being anemic at the point of surgery versus having a normal haemoglobin. So this is looking at length of stay, readmission rates, and 1-year mortality. So for us, the biggest change in practice that we can evidence from our data is exploring the cause of anemia once it's been identified. So like we've said, iron deficiency is the most common cause of anemia. This figure here demonstrates the increase in assessing iron stores in patients that have been identified as being anemic. This is looking at year on year in one half of the slide. So what's exciting for us is that we can see how things that we've done in our work stream has actually hopefully impacted on this. So 2020 is when we started discussing having a national pathway with stakeholders. 2021 was when the pathway was finalised and issued. So 2022, we applied for the funding and our programme officially started this year. So although it looks like 2022 and 2023 has levelled out, if we look at 2023 data specifically and then split it by health boards, which is on the other side of the slide, you can see that there's been an uplift in screening for iron assessment across all health boards this year, over and above the previous years. So this current year is the bright blue at the front. Hopefully, with the use of the pre-op anemia test set, this should increase so that anybody who's identified as being anemic should have their iron status assessed, and this will help with patient management then. So it hasn't all been plain sailing. I think the main thing is that we currently do not have access to treatment information is what is essential to evidence the full benefits of our programme. So we're interested in transfusion information and IV iron use. There's ongoing work to close this gap, but unfortunately, data accessibility has been the most challenging aspect of this programme. We're continuing to focus on ensuring the delivery of the agreed outcomes and embedding the process. The original pathway was written as a very high level to make it more achievable by everybody. But with the progress made, the level of engagement means that the document is being reviewed and it's going to be written to be more accurately reflective of the activity within Wales. So finally, we're looking at next steps and opportunities. The programme's focusing on preoperative anemia at the minute, but it's always meant to be a proof of concept for evidence and the overall benefits of anemia management. So in the pre-op setting, the majority of patients have a limited window to be optimised if they're picked up at pre-op assessment. Could be less than 6 weeks, and not infrequently it can be as short as a week. This really limits the opportunity for maximising oral iron use, and it is therefore increasingly reliant on IV iron, which has a greater overhead for resource and for cost. By integrating the pathway into primary care or the point of referral, this would allow earlier intervention and improve patient and organisational outcomes. In an ideal world, we would like to expand into other high-risk groups that would benefit from this programme. Obstetrics, elderly, paediatrics, oncology, to name a few, all have high prevalence for anemia. blue sky thinking, if you look into Europe, for instance, this could lay the foundation for potential patient blood management departments within health boards, which would act as multi-speciality hubs to deliver service needs at any referral of anemia based on the pathway. Okay, thank you for listening.
Thank you very much, Stephanie. Well, such an amount of work with all the underpinning training, but just to see the differences in the health boards just this year is just inspiring, isn't it? And I know it's taken a lot of work, and as you say, a lot of relationship building from such a diverse pattern of the anemia issue across Wales. Thank you. So we've got a couple of questions that have come in, so we'll do those after. And I'm going to hand over to Amanda. Thank you, Amanda.
Okay, thank you, Dee. And you should now see the slides, and they should be moving. So where did we start? So I've been asked today to talk a little bit around delivering value in orthopaedics. So what was the current position? So the waiting list growth was around 54%, and baseline activity is about 70% of pre-COVID levels. And when we looked at this by subspecialty, we could see for hips and spines, this was definitely something that there was, we could see variation around Wales. So, I mean, while this presents us with one of probably the greatest recovery challenges that I've seen, it also presents us with an opportunity to do things very differently. And there was a commitment to do this seen by NHS Wales, because there was a commissioning of the Get It Right First Time work, and there was also a commissioned strategy for clinical services in orthopaedics. But what was the value challenge? So the value challenge was, well, do we understand what good looks like at all stages of the orthopaedic pathway? Are we doing the right things for patients? And do we adhere to best practice? So I've categorized this really into three main areas. So standardization of PROMs and use of PROMs across Wales, generating a value pathway of what good looks like, and then creating this data-informed system. So how are we utilising PROMs, and how can we generate information using dashboards and analytics about what we are doing? So if I start with the standardisation of PROMs, and I know this has been covered earlier in the week, but with regards to orthopaedics, so the national team helps with agreeing what the national approach is to PROMs collection and standardisation across Wales. So there are now agreed PROMs to be collected in each subspecialty within orthopaedics, and there's also a time scale of collection. So not just before surgery and after surgery, but a bit like Chris was just explaining, right the way across the pathway. So, and earlier than the referral into secondary care, so we can see what those patients are reporting at every stage. So I suppose then those orthopaedic PROMs have all been licensed for national use. They've all been translated into Welsh, and the translation validation with those patients is very much underway, if not complete, in all of those areas. So I suppose all that work is important because it does avoid duplication across Wales and health boards doing this 7 times over. So then with the national pathway, so could we evidence sustainable value at each stage of the pathway? And this was the first time we sort of looked at this. So we didn't sort of do it in the right order to begin with, you know, when very much we were looking at orthopedics. So we started in this optimizing intervention space. So thinking about, again, what Chris has just talked about and Stephanie about rehabilitation, are those patients optimized before that surgical event? And then within that surgical intervention, do we understand what good looks like? Are we abiding by that good practice, by GIRF? Can we reduce unwarranted variation, low value interventions, and reduce risk factors and complications and use PROMs? But you can spread what good looks like right across that pathway. So in the prevention space, in the public health awareness, you know, do we really understand around the disease? Do we understand lifestyle and weight management? And what recovery following injury looks like, and understand those early symptoms and risk factors. And then going back to very much what Chris talked about, that early exercise and lifestyle program and what that can evidence. And then in that early accurate diagnosis section, it's around ensuring right time, right place for timely diagnosis and that shared decision making. And then through to supportive treatment around supporting and optimizing pre-intervention and optimizing post-intervention. And we'll see a little bit more about that shortly. So once you map the pathway and looked at what does good look like, how did we start to look at this? Well, really, as our learning healthcare system talks about data to knowledge. So can we turn practice into data, data into knowledge, and that knowledge back into practice? So really creating that data-driven systems to generate insights and observations to see, are we doing things right? So the things we do in the NHS, are we doing them right? And then are we collecting outcomes to see if we're doing the right things for the patient? So going back to that data-driven system, I chunked this into 3 areas, and the first was utilisation of PROMs. So the hip and knee PROMs results are now displayed in the Welsh Clinical Portal in our electronic patient record for use in direct care. So this graphic will display all PROMs collected across Wales in near real time. Now, at the moment, this graphic populates, there's a couple of thousand entries in this graphic from one system. But we heard yesterday about the data and technical standards, PSOM, and why they were important. And this is why they're important. So near real-time information can be generated into insights and can be used for those direct care purposes to understand how the patient's progressing over time and deep diving into each PROM to see what really matters to that patient. And then generating insights from aggregated data. We're trying to produce dashboards to help us understand what's happening in our health system and to provide some insights into good practice and variation. And then we've been analysing PROMs to understand, are we doing the right things for patients? And what was important for both of these things is that we had access to the audit data. And now that audit data is now flowing back into NHS on a regular basis, and that's all Wales data. So with regards to the dashboards then, I think one of my colleagues will probably put a link to the dashboards in the chat in a moment, but they are available to NHS Wales colleagues. I'll talk through some insights from the hip dashboard, and there's a knee dashboard. A spines dashboard will hopefully be published in the next couple of weeks, and there's some information there on hands. And this hip dashboard at the moment very much looks at just looking at our process data, some pathology data and some PROMs data. And hopefully in the near future, that will contain triangulated costing data with NJR data and more PROMs data to begin to be able to share that PROMs data in near real time around the system. So with regards to so one of the insights then, so I mentioned the getting right first time review, and they very much promoted the use of the type of fixation, so the type of hip replacement, and this fully cemented hip replacement in the over 65-year cohort. And as we could see, there was variation across Wales. So what we were looking for here under those recommendations is probably the dark blue in this older age group, possibly this green, but probably not the red in this older age groups. And what we could see looked like it was consistent with those GIRF findings around returns to theatre. For that red line, the uncemented line seemed to be higher than other areas. And then with regards to length of stay and deprivation, so there's the variation as we might expect with length of stay across Wales. And we could see that length of stay does increase as age increases. But I suppose the main thing here is all our sites, there's variation across all our sites. And if the guidance is one day to get to same day operating and discharge for these patients, then we're probably a little way off that at the moment. So we need to look at what are the opportunities there. And then when we looked at deprivation, we could see that there were less operations being carried out for the most deprived fifth, and that the readmissions is higher in the most deprived areas. Now, particularly with regard to the operations carried out, this needs further work with regards to what's the prevalence of osteoarthritis across Wales. What does the waiting list look like? Not just what we're operating on, to see if there's any opportunities there. And then very much linking to Stephanie's presentation, we could see that in the dashboard, by linking some pathology data and comorbidity data, that we could see patients with at least one comorbidity seem to have a higher length of stay, this dark blue, than patients without. And as the index of comorbidity increased, so did the 30-day readmission rate. And then linking that data, we could see patients who had uncontrolled blood sugar levels had a higher length of stay, and exactly linking to what Stephanie just said, patients with low hemoglobin also had a higher length of stay than other patients. And then patients seemed to have this higher 30-day readmission rate where there was uncontrolled blood sugar levels, low hemoglobin, or kidney and function issues. And sort of hot off the press, really, I mentioned that we're triangulating some costing data in the dashboard, and just some provisional data there looking at these patients with low hemoglobin result, that we seem to see that there was a higher return to theatre in 2 years, over the last 2 years, but also increased costs for patients. So the green patients who have anemia, there are increased costs, possibly due with the higher length of stay, but could be other factors involved as well. So we've been trying to collate some of these KPIs from the GIRF review into the dashboard, and that will also be available soon. And then an interesting thing from the analysis, I just brought one insight really, because I knew in the dashboard at the moment, until we bring that audit data into the dashboard, BMI is something that we are struggling to electronically pull into that dashboard because the collection and data variability across Wales. So we could see in the Oxford score, there was no statistical difference between the Oxford score, or the gain in that Oxford score, and the different BMI groups. But what we could see is that for patients with who are severely obese, that they reported more severe symptoms prior to an intervention and carried on reporting more severe symptoms than other BMI groups after that intervention. So very much looking at that prevention and rehabilitation space to be able to optimise there. And then how has some service change been influenced by some of this PROMS data? Well, in One Health Board, where that analysis took place, they could see that one implant brand seemed to have some significant difference to others. So not particularly the implant brand, but the cohort of patients. But the implant brand that was being used was the most expensive in that health board. So they've done their own research and have made a change and are limiting the use of this implant brand in that particular cohort of patients. And then we see this more readily now across Wales, using PROMS to facilitate remote monitoring. So in a health board, they've looked at the numbers on this, and they have concluded that 96% of their patients following an arthroplasty procedure don't require face-to-face follow-up, and that's a cost savings of around 20 to 40k, with carbon emission savings also evidenced there as well. So in summary then, what are the value opportunities from the start of this journey? And I say it's the start because there's still so much more to do in this space. So the type of hip fixation influences outcome. So we could reduce this variation and reduce returns to theatre and minimise costs. Optimising health before surgery could reduce length of stay and minimise emergency readmissions. BMI management could improve your outcome. And then if we use PROMs to assess outcomes, we could reduce outpatient appointment demand in that follow-up cycle. And I think that's it from me at this stage. Back to you, Wendy.
Thanks very much, Amanda. I think just the amount of data that you shared with us there, and then the insights would just get bigger and bigger, wasn't it? Because as you look, you're just like, wow, okay, where's the next link? What does that show us? And I think all of the presentations flowed really well, actually. You know, let's look upstream, let's ask, let's look at waiting well. What are the issues? How do we manage them? How do we put in place specific program areas and projects to start pulling this apart? And I think through all of it as well was around the importance of the data, getting the data, using the data, and then the impacts that can have across, you know, across the pathway of value-based healthcare and the elements we look at. So we have had some questions in. So if you're ready, panel, the first one's for you, Chris. So this is from Sophia. Thanks, Chris. Very interesting to hear how you've used PROM to add robustness to business case submissions. I think that demonstrates the strength there. I guess my question is around next steps. Did you get recurrent funding for the service you introduced and enhanced? And once you had the services available, how did you measure the impact to maintain the funding and demonstrate the value for money? There's a lot there. So yeah, so I guess the first bit is around the funding, and then how did you demonstrate you know, what difference the funding made?
So yes, we did get recurrent funding for this project. I'm pleased to say, in terms of how we're measuring the effect and impact of the service against that resource, our KPIs include length of stay. So this ties in with some of the stuff Amanda was just mentioning. So length of stay post-hospital, we're looking at post-op infection rates. And we're looking at reduction in contacts with GP, because we've been highlighting from some of our data that these patients, when they wait a long time, tend to have lots of repeat appointments with GPs and potential escalation of analgesics. Those are the main KPIs we're getting measured against at the moment. So primary care savings, GP contacts, medication prescriptions, and then post-op length of stay and complications. That's what we're looking at measuring in terms of impact.
And were there any areas that had lower than anticipated impact that you thought might be an issue that actually turned out not to be, or was it as you know, did the data play out as you thought it might do?
So we're still in the infancy of collecting data on this project. We got we haven't got any post-operatives. We haven't seen these patients go through, because as part of this project, we've built a prehab service. So it started off, as I said, as a piece of research, PROM data collection, and then what can we do with this data? And it's grown into a service now to support patients and help them wait well. So we haven't seen that full cycle play out quite yet. So I'm really excited to see those patients coming through our service that we're monitoring very closely, and to see the post-operative outcomes in terms of the data we're collecting. So there's two levels to the data collection. So we've got a high level data, which I've mentioned to you. We've also got a separate tier to the PROM system that runs underneath the high level 6 monthly intervals, and that is a pre and post intervention PROM system. So whenever our patients do decide to come in and have intervention, be it exercise, community support, weight loss intervention, we then collect pre and post data. So it'd be really interesting to see our prehab group, the patients that have engaged with our waiting well services, to have a look at their post-operative data against those that maybe haven't chosen to come in and use our support. So, in the next 6 months, we'll have really good data to share.
Fantastic. And I personally look forward to seeing that, and I'm sure some of the people on the call watching it back will as well. So I've got a couple of questions for myself, if that's okay, for you, Chris. So in relation to, you mentioned the recurrent funding, but obviously as the data was identifying all the different needs from the different services like exercise and weight management, did you find that there were capacity issues there that were identified, a bit of a bottleneck? So you're identifying more to go in. Were they able to pick up the patients that were coming through, or did you need additional investment to support that aspect of the work as well?
No, I feel like we've been resourced really well, and it's based on, you know, the data we've pulled in, because we've directly plugged that data set into the business case as accurately as we
Yeah.
can, and it's proven to be fairly accurate in terms of what patients
Fantastic.
need. So we've put the resources in place built on the data we have, and the patient capacity and demand is working quite nicely at the moment. One of the issues we have come up against, because we probably, you know, like every new service in NHS, runs a little bit on before it starts, and we found that there's lots more activity in orthopedics at the moment. So many of our patients we'd have liked to get out to and help them prepare for surgery have actually been called in for their operation before they get to see us. So that's had an impact on our numbers a little bit, but that does mean that we can move from managing our backlog of patients that have been sat a long time, and then move forwards, you know, quicker or more quickly to our new flow of patients, our new patients coming through, which is also exciting, because I think they'll have slightly different demands on the backlog patients, but we're yet to see that, so we'll be able to compare those two data sets as well.
Absolutely, because obviously, as you say, you're dealing with the backlog first, and then you'll be able to deal with as the live ones are coming through, you know, live on the list, I mean,
Yeah.
so that, you know, you can actually pick those up. So really interesting work, and I'm sure that people watching will be really excited to see that, you know, what's coming through, and hear about the modelling as well. So a question for everybody, and I know, Stephanie, you touched on this a bit within your presentation, but I wonder if you could each just take a couple of moments to share with the audience some of the challenges, you know, some of the difficult bits, to you know, alight us all to, this isn't all easy sailing all the time, you know, getting people on board, or, you know, whatever those challenges are. If you could share some of those with us. So I'm going to go to you first, Stephanie, just to give, you know, you were in your presentation, but to give you a few more minutes to share some of that. And then Amanda, if I come to you, and then Chris.
I think first of all was getting the engagement, because we're coming from outside of any health board, really. We don't run frontline for any of the services. So coming in and asking people what was going on in their services, I think sometimes it was seen as a little bit invasive, you know, so for people to be open and transparent so that we could understand what the barriers were, you know, I think we're coming in with like clipboard and auditing and stuff like that. And about trying to say to them that we're like a supported service, we want to make things better. I think slowly we chipped away at it, and we're at a place now where it's like really open and transparent, and people approaching us and being proactive and saying, have you thought about this? And the best practice sharing is really, really positive at the minute, so that's great, but it took a bit of a while to unpick. I think data has been the biggie for us, because again, none of us are really fluent in data or IT. It's a completely foreign language, and I think I'm getting to the point now where I'm like conversational IT, because it feels like sometimes you'd be having discussions and what you're thinking, you're asking for, is getting lost in translation. So then, yeah, it's like loads of back and forth, and yeah, and the systems just don't link up at all. So even though we have ownership of the transfusion or the units of blood before they leave the Welsh Blood Service, once it gets into the hospitals, we don't get visibility of them, which people don't realise. And then trying to understand what's actually happening with the blood. So it's sat in the silos in the transfusion labs. We can't get access to it directly. So yeah, just getting the data all lined up is an absolute nightmare. So I know in the future it's all going to pan out nicely, because we've got the national data repository coming online, isn't it? But it's going to be a bit of a slow burner, I think that is. So we're looking at building something in the interim and all the hoops and governance around that. So yeah, I think that data is the biggie for us, and you just need it, don't you?
Yeah,
which is a problem.
Perfect. And you also picked up David's question as well. So David had put in the Q&A around issues of data sharing and access. So fantastic. Amanda, what about some of your challenges?
Yeah, well, I think as you just mentioned it, exactly what David has mentioned in the chat there, because I think firstly we need to understand that, you know, we're very rich with data, but how do we use it? So there's data available, but we just don't use it. There's data that's collected, but is not accessible because it's locked away somewhere, and there are issues around trying to access that data. And there's data that we just don't collect. And I suppose PROMs did fall into that, and lots of data when we try and look at what good looks like in that sort of prevention or community space. So there's kind of three areas of data there, and it's trying to untangle all of that and what that means. And are things okay as a proxy measure, or do you really need that exact data? And if you do, how do you then go about to acquire that data in the right way? So and I think throughout that journey, I suppose some of the barriers are it takes time, and we are trying to enable, I suppose, in the background a lot. So it might be very easy to be able to say, well, I just want to view the PROM in near real time in the WCP. But I think it's all that enabling work in the background to allow that to happen, which I think probably comes on to David's other question around integrating with the core systems, because yes, it's a big challenge. But yesterday, as I've mentioned, we heard about the PROM standard operating model, which will allow the ability for PROMs to be shared in near real time from suppliers. So it's not locked away in suppliers' platforms, immediately into the health board, and then centrally. And then we've got the opportunity then to really use that data, integrate it in our core systems, and be able to, use it for direct care with individuals or for aggregated analysis. So I think in with all of that, I suppose, it's about this takes time, and it's not something that we can instantly solve overnight. I think we've come a long way. There's a lot to do.
Yeah, absolutely. And I think you both touched on the difficulties of data there as well. And when it's not your data, how do you get agreement to have it? How do you get access to it? The piece on will definitely be helping all of us. And I think there's a number of elements to that as well, in that we're really keen that patients be able to access their PROMs and their PREMs, and to actually manage and track their progress as well, which will be really exciting, Chris, I imagine, from some of the work you're doing, and could act as a bit of nudge theory as well. What were some of the challenges that you faced around data and wider in order to be able to feed that so accurately into your business case?
Looking at the overall challenges, I think getting buy-in really from all stakeholders. Prehab's a fairly new concept in the NHS, particularly in orthopaedics. So to get everyone around the table and to really lean in and be involved and see it as a important intervention that's required for these patients. That was one of the first challenges. Managing the non-digital patient is an ongoing challenge, and making sure we're catering equally and fairly for everybody with all levels of digital literacy is another challenge. And I think working with external partners, so partnership, working with technology companies and third sector, etc. And again, the IG and everything in place around that. I mean, talking of blue sky thinking, we always get these great ideas, but sometimes the work and the legwork is required to get these partnerships working and tied into NHS working and sharing data across systems with external partners, patient data, and the IG that's required is sometimes goes unseen and requires a lot of consistent work by somebody in your team that needs to pick it up, and it's often the bit that's forgotten about. So those are some of the big challenges I've had over the last 18 months.
Yeah, absolutely. And the IG is so important, isn't it? It's the data, the data, as we've shown, is so important, and yet we do need to protect the rights of the patients and the information that's being shared, and also that what we're collecting, we're doing something with it that is useful, and in the best interests of our populations. I just wanted to pick up on one area you mentioned there as well, because often with blue sky thinking, we think everybody's digital and they're not. So how do you in your service balance being able to support the non-digital patients as well as you support those ones that are digitally supported?
So lots of different ways, and as I said, it's not probably a polished system yet. We're still learning the needs of our patients and our population. We do know around 15% of them are probably come into that non-digital category. The other issue we've had is lots of these patients have been managed retrospectively, so the buy-in then from the patient is more challenging. So a patient that's gone through the pathway, seen a consultant, been listed for surgery and told that they need to engage in a digital pathway if they can, is very much different to a patient who receives a letter that hasn't had that conversation from their surgeon. So at the moment we're dealing with that cohort, and that's been more tricky because I think there is uncertainty in the public of, you know, the value of these types of interventions. Why suddenly do I have to provide all this health information when I'm waiting for surgery? Do I have to go and get involved in these surveys and questionnaires? Do I need to get involved in physio? Will I be taken off the waiting list? They've got all these questions in their head because they haven't had those conversations as best as we can get our comms to patients. So it is tricky, but we offer, you know, if they can't get onto a system digitally and they have nobody else in their house, family, friends that can support that, we offer a telephone support service that can help patients to register. And then we've got the offer of all of these services outside of the platform as well. So there is a straightforward traditional offer of a letter to come in for physio, to come in for diet should they need those services. So we're running different you know, models of delivery at the moment and seeing what sticks with patients and what they need, and no doubt that that'll change and be fluid with time.
Absolutely. Thank you very much. So I just want to thank you all for joining us today. It's been a brilliant session, really insightful. I'm just going to sort of ask you now, what do you think is the one thing, your next thing that is absolutely key that you want to achieve with your work? So what's the challenge to everybody now that we can learn from what you've been doing or get involved in the training, Stephanie, for health boards or whatever? But so I'm going to hand over to you. Amanda, what do you need from people watching?
So I think the one thing next for us is ensuring that if we can map what good looks like and we can evidence some metrics of what good looks like, then it's really picked up by the clinical networks, who I know are so anxious for data and information to really then be able to drive impact and drive, you know, an increase and, you know, improve outcomes for patients. And I suppose the one thing that, you know, how do we know that is happening? What does that good look like? And I suppose the data that we've shown today, you know, there will be differences in that data, and those PROMS results for those patients will support that information as well.
Fantastic. Stephanie?
So I think the biggest thing for us is just raising the awareness of the issue of anemia, basically. So obviously I work for the Welsh Blood Service, so we want to be more prudent with blood, but the impact that anemia can have on general health is unbelievable. So I know we're focusing on pre-op right now, but I think there needs to be a bigger awareness for the issues of anemia and the impact on general patient public health, really. So that's our biggest thing.
And Chris, in our last 30 seconds, you can wrap us up. So I just want to say thank you in case we all disappear. But next steps now, I know you've spoken about what's happening. So over to you.
Just really get the evidence base to prove the concept and that it's working for our patients. We've got good case study information, and there's generally good worldwide research in this area from other areas, but we haven't got the evidence base in orthopedics at the moment to show that, you know, supporting patients and providing them pre-op care, optimizing their waiting time, can really have an impact on their operation, the success of that operation. So that's, I'm looking forward to seeing some of that evidence coming through.
Fantastic. And integrating it into the care as normal practice. Brilliant.
Yeah.
But thank you all very much. And thank you for your brilliant presentations. I hope everyone's enjoyed the session and look forward to seeing you all soon. Take care. Bye-bye.